right, good morning, everybody. Welcome to the PTI Nice Daily Show, brought to you by the Institute of Clinical Excellence. It's Friday morning. It's Fitness Athlete Friday. Happy to be here with you today. My name is Alan. I'll be your host, currently serving as COO of the Institute of Clinical Excellence and faculty member in our Fitness Athlete division. We're going to talk a lot today about the subscapularis muscle. We'll talk about some dry needling, some retest with range of motion, why we're targeting the subscap, and then we'll get into some exercise as well of things I like to do for the subscap. Before we get started any further, we have some guests here. So Steve is going to come into the frame. He's not in the frame. There he is. This is Steve Stearns. This is our PT student from South College right now. Steve's going to help me out today. We're going to do some bilateral dry needling, and Steve's going to walk us through range of motion assessment as well. So Steve is here, and then our actual patient with shoulder issues is my fiance Megan. So we're going to be needling her subscap and lat today as well. So before we get started, how can you learn more from us out on the road this year? If you're looking to learn from the Fitness Athlete division, you can jump into Fitness Athlete Live next weekend. 2 chances, either in Kansas City with Mitch or down in Hollywood, Florida, which is just outside of Miami with Zach Long. And then you can learn from Mitch and myself in our Essential Foundations 8-week online course. That starts up again on September 13th. So go to ptinice.com and click the courses button to check out all the courses coming your way. So today we're looking at the subscapularis. So why are we interested in this muscle? It's been said that this muscle is the glute of the shoulder. So it has a lot of important actions. We often think of it as a minor rotator cuff muscle, but it actually has a lot of important work to do, especially in our overhead athletes, especially as it relates to the stability of the shoulder. So we know that subscap adducts, internally rotates, and in some cases can extend the shoulder, and due to its attachment on the front of the shoulder capsule and on the humerus, it really keeps the shoulder in place, especially from any sort of anterior shear that the shoulder might encounter. This is really important for throwers. This is important for our overhead folks in the gym, people that are doing overhead lifting, folks that are on the pull-up bar, doing pull-ups, toes to bar, muscle-ups, that sort of thing. So it's a very, very important muscle, and it can be involved in a lot of pain and especially stiffness overhead, especially when we're looking at, do you actually have full shoulder flexion and full shoulder abduction overhead, or do you have kind of good shoulder flexion and abduction overhead, which is the case of most folks. And when we look at treating the posterior rotator cuff or maybe the lat, we find we can get most of the way there with overhead athletes, but that last little bit of missing motion and maybe pain in our athletes can be related to subscap. So I want to show you how to dry needle it, and please note if you don't have any dry needling training, this is not the time to learn. This is not the time to experiment. I recommend you go take some dry needling courses and then learn from somebody in person how to dry needle it. We're going to use dry needling today because it's one of the few ways you can actually reach the subscap muscle and actually get some treatment down in that muscle due to how it's located on the back side of the shoulder blade. So we can get in there with our hands, but it's just not as effective as being able to get in there with needles. But we're just showing it today to show you how to treat it and how it can be effective in a retest model looking at some shoulder ranges of motion. So what we're going to do is we're going to needle subscap and lat. We're going to show you range of motion beforehand, talk you through the needling, show you range of motion after, and then we're going to walk you through the exercises that we would use to reinforce this with athletes out in the gym or as part of a home program. So first things first, how do we get to it? Subscap is going to be arm underneath the head. Lift your head, please. So we need to get down in deep, more medial to the lat, right up against the chest wall. So this can be a risky position. We're right up against the lung fields here. So again, if you have no dry needling training, do not just start needling people's subscap. Please go get some actual training first. So first things first, Steve is going to take some ranges of motion. He's going to look at shoulder flexion, shoulder abduction, and shoulder external rotation. And we're going to see where we're at range of motion-wise before we get started. He's going to call out the motions, and I'm going to write them down.
She's 163 in flexion.
All right, 163 degrees of flexion, so good but not perfect. Being a true patient there.
We're 151.
151 abduction. This is a patient that often complains of shoulder tightness overhead. So we're definitely looking to see some positive change after the needling. Not bad, 85 degrees of external rotation. So all things considered, external rotation is good, but definitely missing about 20 degrees of flexion and about 30 degrees of abduction. So definitely some room to improve here. So Steve's going to go on the other side of Megan, and he's going to needle her right side. Her main complaint is her left shoulder, but we'll target both sides, mainly because she's getting ready to go out into the gym in about 15 minutes. And she's going to do a workout with a lot of snatching and wall balls, and we just want to get her shoulders loosened up before that workout. So, needling-wise, I'll do my best to stay out of the way. Finding the subscap. Again, we're going right up against that chest wall. We're staying a little bit inferior to the axilla, and we're trying to get in that tissue right there. And if we're doing it right, we will contact the scapula as our backdrop. And then theoretically, once these needles are in, I would be holding them so that they don't move and contact the chest wall at all. What I'm going to do is let go of the muscle and then let go of the needle. And then with these patients, if I have to step away, I'm always telling them, once your hand is behind your head, you can't move it anymore, right? Because it could shift and move into the lung field. So we're going to put a second needle there. Normally I would have gloves, but this is my fiance and we ran out of gloves. It's the end of the week. Gloves will be here later today. So I'm going to drop a second one in the subscap. There's a second one, let go of the muscle, let go of the needle. And then I'm going to get into the lat here too. Normally you don't have two people needling one person. It can be a lot for the patient. This is a patient that loves dry needling, so she's fine with it. Got some beefy lats here. We're using 75s for the lats. This is an athlete learning to love kipping pull-ups and toes to bar and all the stuff up on the bar. Doing good. Almost done. So one more in the lat, and then we'll talk about the E-stimulation application to the needles here in a second. Once we get these last needles in. Steve, how you doing?
Doing great.
Steve's just getting to the lat, but that's okay. He's just learning this dry needling. So while he's finishing the right side, we will talk about the E-stim application. So we have this nice unit here at Health HQ. This is the ES160. I'll raise it up for you all on camera. What's nice is it can do 6 leads. It can do 12 needles at once. But more importantly, it has the ability to sweep between different frequencies, which is nice because we want to target muscle activation with this patient. Again, she's getting ready to go lift overhead out in the gym. So we're going to use a sweeping 310 hertz setting, and we're going to leave her on it. Let's see, we got about 10 minutes before class, so we're going to leave her on it for about 10 minutes and then retest some stuff. So I'm just going to hook up these needles. And then while she is sitting on the stem, we don't normally abandon our patients to sit on stem alone, but while she's sitting on stem, we will go out into the lobby and show some of the correctives that we would dose out to a patient like this. So her left side is set up. Hand some of these leads to Steve. Okay, so now we're all set up. So we're going to turn the power on. It's already set up to sweep between 3 and 10 hertz. So it's going to go from a slow thump, pick up, to almost full muscle cramp at the 10 hertz side. This is a more moderate muscle activation frequency setting. We can go up to 620 sweep, which is obviously a lot more aggressive, but we'll stay at 310 here. And now we're just going to slowly turn the machine up. It's going to be hard for you all. Maybe if you're on Instagram, you can pinch and zoom in a little bit to see. But we're just looking to get some muscle thumping of all the needles at the low end, which as it approaches the 10 hertz will stop as the muscle approaches tetany. Wow, that was instant. You ready for it?
Yeah.
You good there? You sure? Okay. Good?
Uh-huh.
How's it over there? Okay, so we're going to turn on the right side. Subscap.
Touch one.
That's all right. And already I can see right side is just not as active as the left. Left side is usually the symptomatic side. There we go. Good? Tolerable?
Yeah.
Okay. So we're going to leave these in for 10 minutes or so. We're going to go on a field trip and then come back and retest that range of motion. So here we go. We're going out to the lobby. Ring the bell if you need us.
Okay.
Alright, field trip to the lobby, to a different table. Alright, so here we are in the lobby. Beautiful. Okay, so we want to strengthen the subscap, but we also want to work on reinforcing the increase in flexion and abduction range of motion that you're going to see that Megan's going to have here in about 10 minutes when we stop those needles and reassess her range of motion. So I like to do a couple things in side lying, I like to do a couple things in long sitting, and one thing in supine. So it helps to have a set of light dumbbells. It also helps to have a heavier kettlebell that you're going to see. We're going to kind of do a pin in self-mob eccentric exercise with one of the dumbbells. So it helps to have a heavier kettlebell as well, and then some change plates for some long sitting stuff. So the first thing I'm going to start a patient with is flexion and abduction in side lying. So Steve's going to be my demo. He's going to lay on the table here. If you've taken our extremity course, you've seen us recommend this. We call it the sideline trio. We usually do flexion, abduction, external rotation. We saw Megan's external rotation was strong and relatively full range of motion, so we don't necessarily need to hit that, but we are going to hit flexion and abduction and sideline. So I'm going to tell Steve, flexion motion is if you were sitting up. You're going to take your hand, bring it up and over your head, just like that. And then our abduction motion is going to be thumb up, and we're going to come up. And we're trying to get elbow in line with ear here. Steve has great range of motion, as you can see. So what I'm going to do is hand him a dumbbell. I'm going to have him do some flexion reps to demonstrate that sideline flexion. Normally I dose this out 3 to 4 sets of 12 to 15 reps, and I have them go from flexion to abduction to external rotation and kind of just smoke out the whole rotator cuff. So he's moving through flexion, and now I'm going to have him switch the next rep to that thumb up abduction. And now how I like to dose this is I like to go fast to 90 degrees. And then once we cross 90, I like to cue the patient to do a 3-second lower so that we're eccentrically controlling the abduction. That gets a really good stretch into subscap and helps reinforce that abduction range of motion. So Steve's going to lift normal to 90, and then he's going to take 3 seconds to slowly bring his elbow to his ear overhead and then go back down fast. That, again, really reinforces the lengthening of subscap. We know that we're going into flexion, abduction, external rotation, and really working on eccentrically lengthening that subscap muscle. Just like that. Beautiful. So that's what I like to do in side lying. Now Steve is going to flip into supine, and we're going to pretend now and ignore that we're working the right shoulder and go to the left just for demonstration purposes. So if I have Steve scoot to your right a little bit. You're against the wall. We'll do our best. So with the arm at 90 degrees here, what I want to do is have him grab a dumbbell and then control the motion down into internal rotation. Now what happens is when people are limited here, to get that rest of the range of motion and touch their palm to the table or the floor, that shoulder tends to dump and translate anteriorly. We know that can actually be the cause of their symptoms, right? That humeral head shearing across the labrum, the biceps tendon. That's where that patient can start to develop the anterior shoulder pain that we associate with rotator cuff issues, especially subscap. So what I'm going to do is initially hand Steve the dumbbell, and I'm going to hold a heavy kettlebell on the front of his shoulder. And I'm just going to pin his shoulder down and cue him to take 3 seconds to slowly lower that dumbbell down, like that. The kettlebell will keep his shoulder from translating, and when he runs out of range of motion, you'll usually see the wrist start to flex. We know we've reached the end of internal rotation. Steve's going to come back up and go back down. And once Steve does a couple reps and gets the idea of it, then I'll have Steve hold the kettlebell himself with his other hand. So he's self-pinning his shoulder here. Nice eccentric lower, restoring some of that internal rotation at the same time that we strengthen it, with the kettlebell keeping him from dumping that shoulder forward and shearing across the labrum of the shoulder. So that's another one I like to give. What's nice about this is that we can go the other way and we can eccentrically lengthen subscap into external rotation, which again just helps translate into our overhead motions when we're going into flexion, abduction, external rotation, up and overhead. So we get to work both in supine here, and then we just progress the dumbbell weight. We can progress the tempo as needed. Yes, this is Send It Steve. So that's what I like to do in supine. And then the final one, I like to get the patient in long sitting. So Steve's going to pop up. He's going to get into long sitting. He's going to lift the knee up, either knee. And he's going to take the change plate. He's going to put his elbow up on his knee. And now, either way, just like in supine, we can control into internal rotation all the way down. Same idea. We can't pin with the kettlebell here, which is why I don't like this one as much. But just cueing him, when you feel that shoulder start to move forward, stop, and then just come back up fast. So a slow lower, fast up. And then what's nice here too is we can do the same thing. With the elbow on the knee, we can go into external rotation and try to lengthen the internal rotators. He's there. We're already at 90 degrees external rotation, so we're pretty much there for this patient. But somebody that doesn't have full external rotation can raise up against external rotation as well in long sitting. What's really nice with this is that if you can get the patient set up next to some bands, then they can use bands. Bands are nice because then we get tension throughout the full range of motion, all the way through internal and external rotation, which is great to not only strengthen the subscap, but lengthen it as well. So that's what I like to give out, especially acutely, to treat the subscap and try and maintain these gains that we're just about to see when we go back in the room with Megan. So let's go back on our field trip. We should be close to time being up. So here we are back in the treatment room. We've got a minute left. We're going to shortcut it. It's 9:15. She's missing the warm-up. She's usually late to the gym anyways, so it's common for her to miss the warm-up. Normally I don't throw all these leads just back over the machine because they get tangled. So leads are out, and now we're going to take the needles out. Again, I would always have gloves on, but this is my fiance. Okay, so needles are still in her right arm. I'm going to have her keep her right arm where it's at, but now she can relax her left arm, and we're going to have Steve redo that range of motion and see where we're at. So we're missing quite a bit of flexion abduction up overhead. Let's see what changed after the needling. And then normally this patient would not be rushing out to exercise. They would go out in the gym and do those correctives that we just talked about. So here we are with reassessment.
168.
168 flexion, so we got about 5 degrees. Now we're going to retest abduction here.
172.
173, holy smokes, we got about 22 degrees more abduction there. That's wonderful. And then her external rotation was pretty good at 85 degrees already. Not expecting to see a massive change here, but again, the proof of concept in hitting subscap to improve that abduction range of motion, 88. So we did get a little bit of external rotation too. So 5 degrees of flexion, 22 degrees of abduction, and 3 degrees of external rotation after needling. Now we're going to go out in the gym and reinforce that ideally, but she's about to go hit some snatches, so we're going to cut her loose. So don't overlook the subscap. Needling it is very powerful, but so are the correctives to reinforce it, especially that side-lying abduction. That's the main motion that we're targeting. Missing abduction is why we're going after subscap. And again, presenting with that anterior shoulder pain, that feeling of instability, is really why we're hitting subscap, trying to get that muscle strong and stable and lengthened again so that it can protect the shoulder in our overhead lifting. So I hope this helped. If you have any questions about this, again, please don't take this as proof that you can go out and start dry needling this muscle. Please go actually learn it from somebody in person. But this is what we do in the clinic to target the subscap. So have a fantastic Friday. Thanks for joining us here on Fitness Athlete Friday. Thank you to Steve for being my helper. Thank you to Megan for being our test dummy. I hope you have a fantastic weekend. If you're going to be at an ice course this weekend, have a fantastic time.
Okay.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.